Welcome to the Seniors Flourish podcast, where it's all about helping occupational therapy practitioners working with older adults be the best they can be. And now your host, Mandy Chamberlain.
This episode of the Seniors Flourish podcast is brought to you by the Seniors Flourish Learning Lab. I completely get it. I was once too an OT practitioner struggling at my first real job. I had no mentorship. I had limited clinical resources. I didn't really have that much for patient handouts. And I didn't have anyone to ask clinical questions to. I was struggling. If this is how you feel, check out what the Learning Lab membership can do for you at seniorsflourish.com/learning lab. I challenge you to disrupt the norm, be an occupation-based practitioner, use the evidence to support your outcomes, and just be the best clinician you can be. So check it out and join the Learning Lab today at seniorsflourish.com/learning lab. Welcome everyone to the Seniors Flourish podcast. I'm Mandy Chamberlain, occupational therapist and your host. And we like to talk about everything occupational therapy and working with the older adult. Today, we are going to be talking about therapeutic use of self. And my guest today is Michelle. I'm totally going to butcher this. See? Michelle Yeramian. No.
Yeramian.
Correct me. Yeramian. Like, it looks really obvious, but thanks. She's an occupational therapist from Montreal that we connected, and we're going to be talking about the topic. And I love this topic, and it is one of those things that I always feel like this is part of the reason why OT shine is that we actually use therapeutic use of self. So we're going to just talk a little bit about it, how, we can strengthen these skills. How do we incorporate this, and just kind of talk about therapeutic use of self. So welcome, Michelle.
Hi, Mandy. Thank you for having me on your show.
Oh, I'm excited you're here. I always say I'm excited because it's true. I'm very excited. I just love talking with people and connecting with other OTs. So.
Yeah, it's super cool and an exciting opportunity to be able to speak with you, share our thoughts and clinical experiences, and just, learning, bouncing ideas off of each other.
I think that's actually the key. And that's part of the key of the podcast. I feel like, we want to share I always use the OT love, like we're sharing the OT love. Like how else are we supposed to learn if we can grow, if we don't get to share each other's experiences and listen to other people talk shop, So, and this is a great topic. So let's just dive on in and let's just talk about your OT journey. How did you get to be an occupational therapist? Everybody has their story. So what's yours?
So I actually grew up, I thought I always wanted to be a physical therapist or a physiotherapist, being that athletic, sporty type of girl growing up. And so I was pursuing my path in sciences and I was going to apply to physiotherapy until one day I wanted to shadow a physiotherapist, and my teacher in CEGEP, because we have CEGEP here, put me in touch with an occupational therapist, as at the hospital that we were working with, there was no more physical therapists available for me to shadow. So not too happy about that. I ended up shadowing an occupational therapist and it changed my life. I saw a patient 24 hours out of brain surgery and was just blown away by the evaluations and what occupational therapists look at with that clientele. And I just changed everything, changed my application to university. I just wanted to switch it over from what I had applied into to occupational therapy. And, I guess the rest is kind of history because I got in at McGill. Yeah. So I did my bachelor's and master's at McGill University and have done quite a bit. Our master's program consists of both research and clinical placements. So our research project that I had done was actually the use of technology with the elderly to keep them at home, living safer and longer in their homes.
Oh, that's a great topic.
Yeah, really cool. And then some of my clinical placements were here in Montreal, but I even had the opportunity to do one internationally. So I did one internship in Grand Cayman, which is an island south of Cuba.
That might be kind of nice.
Yeah, very nice. But it was an exceptional experience because I really got to be able to, well, I worked in the local public hospital. And the fascinating thing was that there was one occupational therapist on staff.
For the whole hospital.
For the whole hospital. So she was spread thin. She was a generalist, wore all the hats, which is totally different from how we work here in Montreal. So I did inpatient, outpatient. I even did community rehabilitation. Our clientele was ranging from pediatric to elderly to all kinds of conditions. So that's really where I got this exposed to so much and really find what I kind of like within this field of occupational therapy, where we could do so much and work with such a wide range of clientele and conditions. And so that was a great experience. But now I'm working in an inpatient rehabilitation center.
Okay.
And in a program that's kind of like a mixture. It's orthopedic geriatric, so hip replacements, knee replacements, those kinds of stuff. And then in subacute care, which simply put is any diagnosis or condition that has led for someone to have a prolonged hospital stay and they can't go home anymore or straight home. So they need rehab to regain some of their strength, endurance, or just learn compensatory strategies to allow them to go home safely and engage in their activities. So these conditions can range from organ transplants to cancers and tumors, cardiac surgeries, or really any complication that someone had in a hospital that has led them to stay there and not be able to go home. So I kind of have quite a bit of that mixture right now too going on at work.
Yeah, definitely. And then I suppose you kind of help with placement, long-term.
Right. So exactly. We're really involved in discharge planning and whether that is home, and the goal is often to go home, to go back to what they were doing before. But it's evaluating what is, what are those needs and what's capable within the context of their environments, whether physical or social environments, then to make a decision with the client or patient themselves and what the team thinks is best for them.
Yeah, definitely. And I think it sounds like, having that experience on your internship, having that little bit of everything, sure, it definitely helps when you kind of get into the work and you're kind of working in a specialist area like subacute or something like that. But you can use so many of those skills that you learned in other areas. It's such a nice to have that kind of that background a little bit.
Right. Yeah, so, definitely.
What do you think? So we were talking about today is therapeutic use of self. So what is, how would you define, or how do you see what therapeutic use of self quote is?
So yeah, the way it's true. The way we see therapeutic use of self, to many of us, these words are familiar, but the phrase means so much more than what those individuals' words are. And its meaning is not necessarily obvious to those outside of our field of practice. So when we throw that word around, it's kind of what?
Yeah, exactly.
But when we're working with our patients, it's really important to build a therapeutic relationship so that, things to facilitate their experience and have achieve their outcomes and their goals and make this whole process a collaborative one. But how do we get to build that therapeutic relationship? Well, I think therapeutic use of self is really a tool that we use ourselves in a particular way with an individual patient. So not the same way. We don't use ourselves in the same way from each patient the same way, but in different ways. And it's really the way we use our personality and our insights and our perceptions and judgments as part of that therapeutic process to achieve that kind of relationship and in turn facilitate treatment outcomes or goals or whatever we're working together to achieve. Yeah. And I really do think that it goes beyond building that rapport with the patient or client. And it's not necessarily spontaneous or unconscious. I think you kind of have to think about it and really see how are you going to interact with this person today and how they're feeling and what their, lived experience or what their story is, which will change the way you interact with them versus someone else. And another patient's experience will definitely change the way you use yourself to build that therapeutic relationship.
Yeah. Well, and you were talking about how we kind of throw it around. I definitely I throw it around. I think it's one of those things, like you said, it's just like we use it and we we all know what it is, but like kind of defining it and using it, actually having that as a tool in our toolbox is a completely different thing.
Right.
So I'm sorry, what were you saying?
No, and it's true, because there is even a surprising lack of peer review research or even clarity, lack of this clarity in the research that is out there that's defining it in different ways. But yet it is so essential to our practice and in occupational therapy. And I think we use it even without having to necessarily, title it or label it as that. I think through a genuine sense of caring, these skills and tools can come out, but it's definitely not a straightforward one.
Yeah. So why do you think it's so important for us as occupational therapy practitioners in particular?
I think that, we know that the relationship between the therapist and the client is such an important determinant of the success or failure of our interventions in occupational therapy. And I think that it really starts at the first interaction of building this relationship and using yourself strategically to create a positive and comfortable environment with your patient, to allow them to trust and receive and be receptive of what you're trying to encourage and promote them to do and achieve. And it really is important, because as we achieve that collaborative, if we can instill that trust and reassurance, then they could want to work with us, and it be more of a collaborative relationship and process, which will then lead to the main goal of achieving treatment outcomes and goals and whatever their objectives are. If it's, at the beginning, we set up our treatment interventions based on the goals that we determine with our patients, and to achieve those, if we don't have a good relationship, a therapeutic relationship that they could trust the therapist that they're working with, then I think the end result will be completely affected in a positive or negative way.
Yeah. Yeah. And I feel like, reflecting on it on my own, I was like getting ready for this topic and just kind of thinking about my own experiences and how I use therapeutic use of self. But, I'm thinking about like, how is it so important for occupational therapy practitioners? And I completely agree. I completely agree with you. I think also like kind of keep in mind that it's not like we're just like, quote, prescribing something. We're not saying like, you need to do these XYZ exercises. We do sometimes, right? Like that's part of our job. If you're working on a preparatory, activity. But what I'm saying is like, it's very personal. Like we're digging into the people's, personal routines and habits and their environment and their social, psychosocial or their social and family interactions. Like we're trying to look at them so holistically, and we're getting nosy. We're getting nosy into their personal life, trying to figure out and look at them, like I said, from a holistic point of view, and trying to make some, like, what do we need to do to accomplish these goals? And I think sometimes we need to kind of remember that, not all professions are really digging in on that level. And I think it's important that we actually kind of have to keep that in mind sometimes, that we are getting personal and we are, looking at it from such a different perspective, that we need to use that therapeutic use of self. We need to use that therapeutic relationship to, like you said, enable those, make sure that we're achieving those goals. But like, it's not as like saying like, okay, your knee is hurting. we need to do X, Y, and Z. I know it's not, they look at it like physiotherapists, physical therapists, they look at it a little bit more holistically than that. I'm using that as an example of, but we're looking at so many things that we need to make sure that we are, using that tool to achieve those goals.
Right.
And so I think it is a bit unique to OT practice in that way because we are,
right.
I don't know.
And I think that it allows us to make sure that we're not missing anything, any factors that could be contributing to why they're not achieving their goals or why they're not able to engage or where the source of their difficulties are coming from. Because as we get to use ourselves therapeutically and build that relationship, it allows them to lean on us. And maybe as we get to know them, because, if we're working with them closely and seeing them frequently, I may be seeing some of my patients 3, 4, 5 times a week.
Yeah.
I really get to know them, and
Definitely.
Seeing how they act and react in therapy, they're giving me signs, whether it's through their body language or their patience or engagement in an activity. It's giving me more than what physically is, why they may not be able to. Okay, so they don't, like you said, their knee is hurting. It may be affecting why they can't walk, but there's often more things that are going on. And like you said, looking at them holistically and as a whole. There was a professor at my university that made a statement once, and it always sticks to me, and it's so relevant today, but it's treat the person, not the condition.
Yeah.
So yes, maybe of course they're here because of that one condition and has helped them through the healthcare administrative system to get them to where they need to be to get the services. But at the end of the day, we are treating and working with a person, and there's so much more than just that knee pain or that hip replacement. And there are so many other reasons why they're not able to go back to functioning the way they were before. That is beyond the main diagnosis. And you said it exactly, that holistic approach of seeing them as a whole and seeing what else is going on is achieved through this tool of using ourselves therapeutically and being able to get to know them and see what else is going on.
Totally. Absolutely. Do you think, or from your experience, do you feel like therapeutic use of self is more natural for some people than others? I feel like that might be, or how do we strengthen those skills?
I think I would agree a little bit. Some people have, some of it is based on personality. And I think the way you use yourself can vary from one therapist to another. So, it is about personality. And I could give example a little bit in my practice. I tend to sometimes use humor. It's part of my personality, and and of course when it's appropriate, and as I get to know my client or patient, I really get to know their personality and their, and use it accordingly when it's appropriate. But each therapist may have their approach and find how they're able to use themselves, because we as therapists too are, people are humans and have different characteristics, personalities that give us like certain strengths that allow us to bring out the same in our patients. And I think at the end of the day, if you have this general sense of caring and empathy to listen to the patient, I think those are the core skills or strategies that you want to use to be able to strengthen your therapeutic use of self. Mm-hmm. So I think that some people may have it more innately, but it's not achievable. It's finding the strategies within yourself as a therapist, how you could bring out your main qualities to make your patient feel comfortable with you and see that, there was a study done in the American Journal of Occupational Therapy once that explored like this whole phenomenon of therapeutic humor. And they looked at how it could help patients see that therapists are humans too and don't necessarily have the magical answers to all of their patient problems. And I found it really interesting because when you read it about it and you see it that way, it's like when it breaks down that hierarchical level of us being the therapist and the patient being the patient and having separate roles, and having, again, through this therapeutic use of self, this tool, finding different strategies, whether it's humor or something else, can break down those barriers and allow us to both be two people working towards a common goal.
Yeah. Yes. Yeah. But like, I think that there is something to, I'll have to look up that article because I'm kind of like a jot research article nerd a bit. So I love looking at that stuff. But I think, like, I think that's part of it. Personally, this is my personal opinion, but I think sometimes, like you say, if you can break down the hierarchy a bit, I think people feel more comfortable. Like we hear all the time, like things they'll tell us and they won't tell their physicians. And you wonder why wouldn't they tell them that? It's a very important, component to their recovery, but there is definitely a hierarchy and not all, but a lot of some of the, those practices. And when they feel like you are on their level and you just are, like you said, two people trying to accomplish a goal and work together, I think that there's a whole different level of, comfort, and they feel like they trust you, and, it's more of a team effort versus you telling them exactly what they need to do. They know that you're, quote, in charge and you're telling them these are the steps that we need to take, but like this is a team effort. And I think the key is, and I've said this in other podcasts, but it's like one of my favorite things is like, you need to listen to understand, not listen to reply. So like we need to understand what the patient's needs, wants, and desires are. And we're not just listening, quote, listening just to say like, okay, you need to do this. It's like the whole thing, like people will say, as an example, we're making dressing goals. Well, maybe that's actually not very important to them. Maybe they're like, my caregiver's going to do it for me. The caregiver's okay. And you just feel like, well, they should be doing it and like they can do it. But if it's not an important aspect to it, I guess the key is just like really listening to your patient and working at it from a team effort. And I think that's a skill, a part of therapeutic use of self or therapeutic rapport, however you want to kind of go at it. But like, that's maybe like a skill that you can kind of break down and like look at and maybe say like, okay, maybe I need to be a little bit more collaborative, or maybe I need to be, and, cause it's hard to, like you said, explain what it is. Like, what are the skills that you need to have good therapeutic use of self? Well, that's really hard to define. I think. I don't know. It's tricky sometimes.
And I think you actually, have another point in what you just said. This whole reflecting on what you need, what your own opinions and thoughts and judgments are to develop or make this skill stronger for yourself. So this therapeutic use of self, to strengthen it, you need to be reflective and know that it's not procedural. It's not,
yes.
Okay, this is the recipe to how to develop and be better at this, because it's going to vary from one person to another. And you really nailed it. I really love that idea of how, if it's, unfortunately, in some rehab centers, and mine, we have the ultimate goal of discharge planning and what minimal autonomy do they need for this environment or that environment. So whether it's placement or returning home autonomously. Dressing may be a goal, and unfortunately we can't necessarily go around that, but it's very true that if it's not meaningful to them, if it's not a goal of theirs, it's going to be so hard to achieve that. And in turn, it's going to affect your therapeutic relationship. And it could really cause, some challenges because you're not on the same page, and you're trying to push for something that is not what's like important to them. So
yeah. Well, that's why that's such an important part of occupational therapy, being client-centered. And, making sure, yeah, because if you start saying like, we have to do this, we have to do that, I mean, people are going to shut down. They are not going to want to participate. They're not going to want to like do any of the things. They're not going to say like, I don't really need occupational therapy, because that therapeutic rapport or therapeutic relationship has been kind of damaged a bit, because they don't feel like they can trust you anymore. And it's hard because we have our quote job to do, our expectations, the demands of our facilities and the insurance companies or whatever, everything else that goes into it. And so it's like really hard to have that healthy balance, trying to figure out what everyone needs and everything. What?
No, and just at the end of the day, I think that we have our plan, and it's good to have our treatment plan in mind and our goals. But sometimes it's, we got to throw that plan out the window and sit down with them and see what's not working for them, it's not taking 10, 15 minutes at the beginning of your session when you see it's not going well to address it and acknowledge it will help in the long run.
Yeah. And like, obviously our healthcare systems are different, but like, I think sometimes people, feel like they can't take that time to understand your patient or review goals or really get a good, therapeutic or rapport with their patient or whatever you're trying to achieve. We can absolutely still do that, and we can actually still quote bill for it, because it's part of the OT process. Like, we are not able to even achieve the goals if we don't back it up and like look at the core, like get a good understanding. Like, why don't they establish, let's say, a goal, they want to be able to get dressed independently. Okay, I'm just throwing it out there. That's a really broad goal. Yeah. Probably don't use that goal, but like they want to get dressed. And then you're working with them and they're like, they don't want to work on it. They're not doing it. Like, what's going on? Like, we need to actually use our therapeutic use of self and get a good understanding of what's going on, and talking to them about that, or saying like, okay, what are obviously wouldn't be like, what are the barriers, but like figure out what are the barriers. It may be something really, basic, saying like, I don't like getting dressed at 11 in the morning. I should be doing this at 6 and blah, blah, blah. And you're like, okay, like if you don't have that conversation with them and have a good understanding and use yourself as a tool to find that out, like then you are like, everyone's denying me today. No one's participating. But we have to kind of break it down, I think, a little bit more and use those tools in our toolbox and figure some of those things out.
Yeah. And in terms of that billing and whatnot, it definitely helps in the long run in terms of effectiveness, because if you could address it as soon as it starts appearing as an issue or something's not working, well, instead of letting it go and then, having, again, our systems may work differently, but having to prolong the number and length of treatment sessions, if we kind of can tackle that at the beginning and make sure that it doesn't build up internally, within our patients, and have that as something that's growing, but they're not voicing it, or they don't feel like they can share that information, then our effectiveness not going to be, we're not going to be as effective, because we're going to have to keep them, they won't be achieving their goals, or it will be taking longer to achieve those goals. So I think in terms, investing a little bit of time this way and using this tool early on will help effectiveness in the long run, and not have to let that build up and prolong stays. So.
Yeah, definitely. Do you have any like good stories or any kind of examples of how maybe you've used therapeutic use of self in your practice?
I have, so again, I'm working in an inpatient rehab.
Very different. Yeah.
Very different. But in my context, I'm really fortunate. I tend to do, when necessary, home visits. So the purpose of the home visit is really to assess or to evaluate the accessibility of the home. If they have any still residual physical difficulties or impairments. So the accessibility, if the need for equipment, or any recommendations around the home adaptations or whatnot to ensure that discharge. And we also promote during their hospital stay, if it's possible, again, within environment, the physical environment steps or whatnot, or socially, if they could go home, if there's someone that's going to be there with them or not. We try to encourage at least like temporary discharge over the weekend. So kind of like a weekend or a day pass go home and then come back, and it allows us to and the patient to evaluate what still needs to be worked on. And sometimes other barriers or other things appear, like, oh no, we totally missed this. We haven't thought that in my home I have this, that, or the other thing that will be difficult. But I love doing home visits, but I have to acknowledge the fact that when you've been away from home, hospitalized for a prolonged period of time, that first visit home tends to be very difficult. Mm-hmm. And I think that it always brings me back to this idea of, how am I going to use myself? Because I have the goal to evaluate, why am I doing this home visit? It's to evaluate and the accessibility. And I have all these objectives that I need to achieve while I'm going there, but I can't just, go there with my checklist and think that it's all going to get done in an hour, and then see my patient's face the minute we walk through the door. And it's so emotional for them to go back into this, especially if it was something, it wasn't an elective surgery or, something traumatic happened and, they didn't plan for this hospital stay. So now they're coming back into an environment that they knew themselves previously, and now they're possibly in a different state, a different functioning at a different level, or not exactly the way they were before. And so I think that those situations really, those home visits really allow me to bring out that, okay, I'm going to need to support and follow them through this event, because it's something that's not easy for them. And while I have my checklist and purpose of being there, I have to find a balance between how to coach them and encourage them and support them through this, because it is part of the journey. And, to face the obstacle and difficulties of this first home visit and this first home stay or outing, in their rehab process. So it's bigger than just what our quote job is to do. It's just, there's just so much more to look at and be sensitive to, and use your therapeutic use of self to help them feel as successful as they can and go through the process. Yeah. I mean, and I think there's so many ways and there's so many examples of how we can use therapeutic use of self. And even some of the basics, like, people, you're doing an evaluation. I guess one example I can think of is like doing an evaluation, and you have some of those people that are just super leery. I can think, okay, let me back up. So there was one situation I was in skilled nursing, and the lady came in, because of a fracture. But she obviously has some cognitive limitations, and the husband the quote caregiver had some cognitive limitations, not more mild, but they were very, very apprehensive to do an evaluation, just because I feel like I could sense from the beginning that they were very standoffish. They didn't want to answer any questions. They were dead serious. I think they were just nervous, and I could just feel when I going in there that they just, one, did not want me there. And two, I think in the long run, looking back, they were really scared that we were going to quote, keep them there because, she had a fall, she had a fracture, she's in the skilled nursing. They cognitively have those limitations. And it's like they were the husband was at that stage where he was aware of it. But he was just, they wanted to make sure that they could go home. So they were really trying hard. I could tell they were really trying hard of what they were saying, how they were explaining things, being very purposeful with their, during the evaluation. And I'm trying to make them feel as comfortable as they can. I knew I couldn't go in there and be this stern and be okay, this is what we need to do. And you use those, that therapeutic use of self to make them feel comfortable, let them know that you are on the same page as them, know that we're on the same team, figure out what our goals are, and, try to get that through. Because we had, another team member, and obviously I'm not telling this story to say oh, Mandy, you are amazing at this, because I have so much to learn and we're always learning. But you have those times where you just connect with people.
and you have a coworker be like, they didn't do anything for me. And you have those times sometimes when you're like, oh my gosh, I'm getting somewhere. I feel like they're trusting me.
Right.
And, it's like you said, it's more than just like building rapport. It's really kind of actually getting a feel for them and reading their body language and, listening to what they're saying to you or what they're not saying to you, which is easier said than done sometimes. And I definitely do not get it perfect every time but with this couple, I just felt like my evaluation, it ended up taking longer than you planned, which is always tricky because like you feel like you're always on a time crunch. But I also felt like it was very therapeutic, and I felt like they trusted me because of the process. And so I think it's those types of things that you have to kind of just be aware of, that sometimes you have to go in there. And as OTs, I think sometimes we like to think, I mean, I'm definitely that person. Like, I feel like I'm so flexible. I can go with the flow. But the truth of it is we have so many other demands. And so we have to kind of prioritize a bit. But like that one sticks out, to me a lot, that couple, because I just felt like I actually really used therapeutic use of self to really get a good understanding of what was going on, and kind of just reassuring that like, my job is not to like keep you here or, but my job is to enable you to be independent as possible and be successful. And it was a lot of work because it was also in the long run, it's like, making appropriate goals when someone doesn't like totally open up to you, or, they're like, I want to go home, but they won't tell you about the home situation, or the like, okay, like you're pulling teeth trying to get some information out. But like, maybe we need to spread out that evaluation, over 2 visits if you can, depending on your facility and setting and that kind of thing. Or, maybe they need a little bit more of just a listening session and gathering information that way, more conversational instead of like a checklist. Or like, how do we use our skills as an OT practitioner and use that therapeutic use of self to get the information that we need and help them become successful? So
yeah,
I love those. I love those like situations when you're like, I nailed it. Like, as in like, it was a win-win for everyone. Like, I don't know. I think that's kind of some of the rewarding parts of being, in the occupational therapy world. So.
Yeah. I think communication and transparency, like you said, saying why you're doing what you're doing and what you're looking at, as being as transparent as possible, will allow them to, or, to open up to whatever evaluation you need to do. That totally reminds me of, I don't know if you have to do driving evaluation or driving safeties. I don't necessarily do on-road driving evaluations, but definitely after a hospitalization, there are maybe certain reasons why someone can't drive. And that's such a sensitive topic. It's not an easy one to tackle. And I personally find it a very challenging one because it makes me so reflective on the consequences, whether I agree that this person is safe to drive could or not, has severe ramifications of their either safety or everyone else's safety on the road, and if they are deemed not safe to drive, then the ramifications of their autonomy and how so that it's about being transparent and communicating why it's important to do this evaluation, and be transparent about the consequences, and try not to hide anything, because that makes them close up as well and more likely to not want to go through with the evaluation. So you've got it. Communication is a really big factor.
It's a key. And I tend to overtalk sometimes. So I always like try to really focus on like listening, but communication. So like, okay. So we talked about like, it's really hard to put like what the skill set of therapeutic use of self is, but I guess we kind of touched on some things. Communication, I would say, is probably one that we talked about, obviously listening,
observing their reactions and actions, that whole nonverbal body language and whatnot says a lot.
Yeah. I would say some of those are some key. I'm sure there's probably more to the actual,
Right.
but those are some of the, like, don't need, like I said, a checklist, a little checklist, but like something to be reflective. I think that's the big thing, like you were talking about earlier, is like being reflective on what's working, what's not working, and why is it not working, and what approach can I,
Right.
go at to be more successful.
And unfortunately, not everyone's the same, both therapist and patient clients wise. So I guess you would have to say that the main one is being reflective, because to see how you could adjust yourself and use yourself therapeutically with each individual client or patient, and finding that. So you've got it.
Yeah, I kind of got it. I'm working on it.
I don't think, I think like it's not something that we could ever say that we've mastered.
Right.
Because we're all going to have, you just sometimes, even if you're really good at it, you sometimes click more with certain patients or clients, and it just is easier to get through to that openness and have a strong therapeutic relationship. And some people, it's just a little bit harder, and you just need to dig a little bit more and adjust yourself accordingly to accommodate to their needs or what they're feeling or going through.
Yeah. Well, and it's like, you have those patients that you go, it's just being able to read people a little bit and get a good feel. But like, like you have those patients that I like to use therapeutic humor a lot as well. I think it's just like an icebreaker as well, and just kind of makes people feel a little bit more comfortable. But like, you go in, you start the evaluation, you kind of, start communicating, and right away, nah, I might have just lied. You get a feel sometimes for people that you're like, okay, they want someone a little bit more lighthearted, that we can get the job done. We can, that kind of thing. And sometimes you go in there and you're like, yep, they want the facts. They want to know what they're doing. They want to know the steps they need to take. So your approach does need to be, since we're using ourselves as a tool, we need to adjust that tool to our patients. We can't expect those patients to adjust to my lighthearted, humorous personality when they're like, that is not going to fly. So, you have to adjust and use it. And that's a skill in itself. But sometimes it takes experience, but we can definitely be reflective and kind of figure out those things, make it a little bit easier.
Yeah.
Okay. Gosh. Great. Good conversation, Michelle.
Right,
I think it's, especially this type of topic where it's not as like a cut and dry kind of thing. I think it takes conversation and processing and, batting ideas off each other to kind of really get to the quote bottom of it. Is there anything that you feel like people need to kind of take away from this conversation?
I think the one thing we didn't say is that, well, I mean, of course it's not necessarily easy, right? And maybe we touched upon that, and we have all had some challenges, or we may cross paths with a more challenging situation, because people are humans and are multifaceted. So I think that it's okay to not have a perfect, easy journey with each patient, that there are challenges along the way, and it's how you use yourself and reflect on what their needs are to not get discouraged by it, because we are, as therapists, are humans too, and if we care about what we do, and we genuinely care for the outcomes of the patient, it's hard to see that our patients are not doing well, and to see that despite all our efforts, we're not getting through to them. So yeah, it's just so fun to talk about all the encouraging stories and the great ones, but to admit that there are some challenges sometimes, and that it's not easy, and sometimes it takes more work and more reflection and more time to get beyond those obstacles and barriers, and to lean on whatever resources you could find, whether, like you said, colleagues, anyone else in your team, or family members of the patient. Like it's to use everything. It's not a straightforward thing. It is complex, and we just got to use all the tools in our toolbox in occupational therapy to get through to that. And it's a complex
Yeah, it's very complex. And yeah, that's actually when you almost feel like you need to, quote, use therapeutic use of self the most, is when you have the challenging patients. You know, you're just like, oh my gosh, you don't know what else to do. And so reflect, figure it out, new approach, listen. You know, it's like, okay, those are the ones that you're like, okay, let's crack out this therapeutic use of self and see what the angle we can go. But it makes our job fun, I think. And those are the challenges that you /hate, but / also like when you can get through it, you're like, oh yeah, that was good.
Like, learn and develop and just acquire new skills and kind of see that you're constantly learning and you haven't mastered it all.
And if you're not, you should be. No, like, you know what I mean? Like, I feel like that's part of our job. Like, we should always be learning. And I actually feel like it helps with burnout. It helps with feeling stagnant. I feel like it helps with so many things on even just a professional level. So, yeah. But anyway, I'm just going to I'm going to dig up that AJOT article and link to that in the show notes because I love a good therapeutic humor. Gosh. Thanks, Michelle.
Thank you, Mandy, for having me. It's been an excellent chat, right? Really stimulating.
Yeah, thanks. And thanks, everybody, so much for listening. So until next time.
If you are an occupational therapy practitioner that enjoyed today's podcast, I invite you to check out the Learning Lab at seniorsflourish.com/Learning Lab. The Learning Lab is the essential resource for OT practitioners working with older adults looking for more treatment ideas, support, and resources to be the best they can be. So whether you're struggling to find evidence-based treatment ideas, you don't have time to research for resources or patient diagnoses, or are even looking for ways to earn more professional development units, then the Learning Lab can help you become a more effective and efficient practitioner. With weekly educational videos, a huge resource and handout list, a bi-monthly journal club where you can earn professional development units, a supportive community forum, and even some exclusive member-only bonuses, the Learning Lab is the perfect place to help you be the best OT practitioner you can be. It's like having your own OT help desk. So check it out at seniorsflourish.com/Learning Lab. Thanks for listening. This podcast is brought to you in partnership with the Jaros Collective, a podcast network that's redefining old and equipping healthcare clinicians to better serve our aging population. Find out more at GEROScollective.com.